Good evening, everybody. It's a perfect pie of audience, physicians, investors, entrepreneurs. I have not seen this kind of audience in any one single forum. Thank you, Dr. Uli. So I'm representing Curie. I'm a co-founder and head of AI at Curie. At Curie, we are focused on chronic respiratory conditions. And we are also focused on helping physicians, specifically physicians that are working in value-based care models, like Medicare Advantage plans. And I will also start with a quick background about Curie. Curie is a spin-out from SRI International, Stanford Research Institute. Some of you may not be familiar with SRI International. So some of the pedigree for SRI is companies like Intuitive Surgical and Siri that was acquired by Apple. They were actually the past spin-outs from SRI. And Curie was spun out from SRI International in 2017. And a quick recap on the background of the co-founders. So I'm Sridhar Nemala. My background is in AI, augmented intelligence, not artificial intelligence. So I've been working in the AI for the past 20 years. I'm a technologist. I've developed technology that was shipped in hundreds of millions of devices, generated at least $500 million revenue. And my other two co-founders, Navya and Ravi. Navya has a PhD in biomedical engineering. Ravi was at Facebook. Ravi is in charge of all things related to engineering, and Navya is the CEO. So now, coming to the problem, we are looking at chronic respiratory conditions like asthma and COPD. And if you look at these conditions, the prevalence is very high. Like 1 in 8 people in the US have one of these conditions, more than 40 million people. But more than the prevalence, what is the more worrisome thing is close to 60% of the people that are diagnosed with these conditions have uncontrolled condition. So that is, so they experience symptoms very frequently, and that can also lead to frequent exacerbations, which in turn can also lead to millions of ER visits and hospitalizations. So I'm actually showing some statistics. More than 5 million ER visits and hospitalizations happen every year. And if we actually look at a specific population, senior population, 65 years and above, they actually account for more than 3 million ER visits and hospitalizations. So in terms of actually working with the value-based care models, physicians, we're actually focusing on high acuity patients, elderly population, 65 and above. And when looking at this problem, why the standard of care, what are the shortcomings in the standard of care? Why the status quo is like this? Why there are so many ER visits and hospitalizations happening? Why is a large percentage of the population have this uncontrolled condition? We have come up with two broad issues. So one is patients that are diagnosed with one of these conditions, they receive a treatment plan, and the treatment plan, following the treatment plan requires subjective assessment of symptoms, and then accordingly choose the medication and take the medication. So one simple example is, it is up to the patient when to use the rescue inhaler. It is up to them. They need to subjectively assess themselves, and they need to use, when appropriate, when required, that rescue medication. And there's a lot of subjectivity to it. Some people actually may not actually follow this treatment plan. And that is one of the key contributors to the largely uncontrolled statistics that we're seeing. And the second important aspect is physicians that are caring for this population have very limited visibility into what is going on with the patients. I mean, they get to see them only once in a while during the office visits, or in the unfortunate cases, I mean, in the ER visits and hospitalizations. So there is a very limited visibility into what is going on with the patients. So these are the two broad gaps that we are looking to address with a very innovative solution. So our solution at a high level has 2 to 3 components. So the first component is we want to enable very, very high visibility into how the individuals and the patient population is doing to the clinicians. And for that, we have created a very transformative AI technology that I will come into, I'll give you more details on, that we are calling intelligent health monitoring. So through intelligent health monitoring, we can understand how an individual patient is doing on a daily basis, how the patient population is doing over a period of time. And we can relay all these insights to the clinicians in an actionable way. So that piece is actually the HIPAA-compliant secure clinician platform. And there is also a third component that is a patient mobile app that we can use to engage with the patients, that we can also use to deliver the treatment guidance and so on. So those are the three high-level components in the solution. And now coming to the intelligent health monitoring. So when we are enabling this monitoring for the individual patients, we give them a monitoring kit. That monitoring kit has two sets of devices. So one is a device that is to use this passive continuous monitoring. We do not require any change in the patient behavior. It's completely passive. It's completely contactless. And I'll get into more details how exactly this works. That is a passive continuous monitoring. And we also have this active monitoring piece. And we use this active monitoring piece very judiciously because, I mean, this is also in our experience. We ask for a peak flow data. We ask for a pulse oxy data, no matter how seamless we make the experience, no matter they are connected devices. The long-term compliance to getting this type of data is less than 10%. So even in our deployments. So this is really why we are combining passive monitoring along with the active monitoring. So now coming to the passive monitoring. So this is our core IP. So this is our, so this is also actually the technology that we licensed from SRA and so on. So more than 10 years of research and development went into developing this technology. So the way this technology works is, I was showing a tablet device in the previous slide. So that tablet device, we typically use it in the practical setting in an overnight monitoring scenario. So again, some of these respiratory illnesses, if there were to be symptoms, those symptoms tend to get worse typically in the nighttime, in the late evenings, in the early mornings, and so on. So again, I mean, this is for the practical implementation. So we can actually monitor the patients completely passively in a contactless manner every day. And this is what we are using. So this tablet, this is a cellular connected tablet. This just actually looks like this is also, I actually also got one device. This is on the table there, over there. So this tablet kind of device just acts like an alarm clock that goes on the bedside. It just stays on the nightstand. And again, this device need not be actually close to the patient. It can even be a couple of feet away. So now what we are doing is, we are using a Alexa type technology. So when you have this Amazon Echo, it is continuously listening for audio, and it is trying to detect the pattern Alexa. So similar to that, we are continuously looking at the audio, analyzing the audio, and detecting a variety of respiratory health biomarkers. So is there any chronic cough? Is there any sneezing? Is there any difficulty breathing? Is there any shortness of breath? So we are detecting a variety of such symptoms. So now from this information, I mean, just some more details on this. So to be able to actually train this kind of technology, it's a very complex system. And again, all the AI runs on the device. I mean, there's no issues on the privacy and the security and so on. And we have collected data on thousands of patients with asthma and COPD. And so far, the AI has been trained on more than 1 million hours of audio with annotated symptoms, more than 16 million annotated symptoms. So more than 16 million annotated symptoms. So audio annotated with all these symptoms. Those are the respiratory health biomarkers. There is a coughing, there is a shortness of breath, there is an audible wheeze event, these type of events. So now from this passive monitoring, we understand if the patient is undergoing any kind of respiratory distress, what is the level of respiratory distress? And then during the day, we engage with the patient. Can we actually get a pulse oxy reading? What is your oxygen saturation? How is the heart rate looking? What is your peak flow reading, and so on? And with this type of approach, this we are actually calling a passive monitoring most of the time, only when required active monitoring. With this approach, we have actually we have seen great compliance actually in getting the data, in getting actionable data. And the second and third pieces are this HIPAA-compliant clinician platform that will enable workflow optimization and both proactive and personalized care. And we also have this patient-facing mobile app. So in a sense, this is what we are enabling. For the first time, clinicians have the ability to actually look at the data, how a individual patient and patient population is doing. And the unique advantage being, I mean, we can not only detect the early development of symptoms, we can track their progress if they're actually becoming worse, and we can alert the physicians even days in advance that there is a very high likelihood of exacerbation. And we also create this personalized profiles based on this longitudinal data that can even be used if a particular treatment is working or not, how well the particular intervention treatment is working. And we also do this daily stratification, risk stratification that can be used for workflow optimization. So, I mean, I'll be happy to show you a demo. So I'll be over there. Yeah. Sure.
Okay, great talk, great talk. So, how do you eliminate the noise of your data, real data noise,
Right.
which is literally here noise?
Right.
Let's say there's a husband and wife
Right.
sleeping, one
Right.
has COPD, one has asthma,
Right.
and you have it like
Right. Yeah. Yeah. Yeah, great question. So when I said actually we trained the AI with more than 1 million hours of audio, so the AI is trained not only actually in detecting these symptoms, but also rejecting all sorts of noise. For example, the spoken content and all other types of noise. That is one thing. So the other thing, I mean, AI also uses a combination of demographic specific models that can distinguish male versus female, that can also distinguish different age groups with a high accuracy. So we can actually, in most of the cases, there are still some corner cases. In majority of the cases, we can actually detect the symptoms from the participant of interest. So the go-to-market strategy is we are partnering with provider networks, payers, specifically working in value-based care models, Medicare Advantage plans. And so we are specifically targeting the provider networks that have incentives for providing low-cost, high-quality care. And we charge between $50 to $100 per participant monitored per month. And again, the idea is, for example, in the first pilot we have completed, we had shown more than 90% reduction in the utilization, more than 90% reduction in the ER visits and hospitalizations. So that is a value proposition. We'll actually reduce the utilization, especially for high acuity population. Yeah. Yeah, great question. I mean, something related to also the noises. For example, some of the noise types we have collected for training the AI also include noises generated from these CPAP machines and so on. So we actually reject those noises in the AI. Reject the noise. Yeah. Yeah. Right. These trackers that everyone's kind of bringing to the table now. Right. And what I don't see in your slides is that you've got a really good signal identifier. Right. And it allows a clinician to bring in the signal and kind of you're doing the filtering out of the noise for him, which is really poignant and valuable. And I don't yeah. No, that's a great point. Actually, for example, I mean, this first pilot outcomes. So as part of this pilot that ran for close to 8 months, Overall, we have collected 36,000 clinical information data points. No, no. So out of this 36,000 clinical data points, we have only prioritized 990. So these are the points that are prioritized with actionable insights. So these are the points. These are the only points that are consumed by the clinicians, by the physicians, or by the nurses.
So, how would you compare this to, let's say, you had the ability to monitor from breath to breath, tidal volume and minute volume, as accurate as an administrator?
So I think so again, the advantage here being able to do completely passively, contactless on a daily basis. So this works 24/7 by 365. So that is the key advantage. And also we are working with some of the pulmonologists. When they I actually skipped a lot of the details. I mean, I'll actually show some of those details in the demo. For the very first time, physicians are able to actually listen to the symptom evidence. When we actually say there is a difficult breathing, there is a chronic coughing, these type of events present, the patient went through, they can actually listen to all that symptom evidence. And they can actually understand what kind of symptoms that the patient actually went through.
I guess my only question would be, that's an empiric measurement, whereas this is an exact measurement. This is what we use to diagnose.
Right. So definitely, I mean, those kind of measurements are applicable in the active monitoring case.
I guess the question is, what is the accuracy as a term,
Yeah.
This versus just the conventional.
Yeah, there's no conventional.
There's no conventional.
That's the beauty of this.
Yeah. So there's just one more question.
There's also another company locally called Spirosure.
Okay.
They're actually in Pleasanton, and they have it's called Phenom, but basically it measures exhaled nitric oxide for asthmatics. When the exhaled nitric oxide
Yep.
actually goes up, it's time to actually, it's more inflammatory, right? So you need to start steroids. So it helps determine when to start and stop steroids. I'm an advisor to that company also, and there's a lot of synergy with what you're doing.
Yes. Yeah. I'll be happy to actually talk to you right after this. Thank you.